Morning, everyone. I think we're going to make a start. So welcome back to seminars for the year. It's very exciting to all be back together again in person. We're still doing a little bit by Zoom, but it's great to see so many faces here in the auditorium together. And I think we couldn't have asked for a better speaker to really kick off our seminars this year than Professor Chris Sweeney. Before we get into that though, I'd just like to mention a few housekeeping things that there will be lunch served after the seminar, so we really encourage everyone to stay and network, talk a bit more to Chris and to each other, particularly if we haven't seen each other in a while. So firstly, I'd just like to acknowledge the Kaurna people as the traditional custodians of the Adelaide region where our buildings are located. We recognise the people's cultural, spiritual, physical and emotional connection with their land, and we honour and pay our respects to Kaurna elders, both past and present, and all generations of Kaurna people now and into the future. We also acknowledge the other traditional owners who live across South Australia. So Professor Chris Sweeney probably needs no introduction to many of you. You've probably heard that he's arriving and are very curious about what's happening here in Adelaide with the new SAHMRI Institute next door. So Chris is actually from Adelaide originally, for those that didn't know. He actually received his medical degree here in Adelaide and completed an internship at the Royal Adelaide Hospital. He then went to the US and did his residency in internal medicine at Gunderson Lutheran Medical Center in Wisconsin and a fellowship in hematology oncology at Indiana University Medical Center, where he was later appointed the Associate Director for Clinical Research for the Simon Cancer Centre. After a brief sojourn in Adelaide, he then went back to join the Lank Centre for Genitourinary Oncology at the Dana-Farber Cancer Institute and Harvard Medical School in Massachusetts in 2009, and that time's gone so quickly, it's amazing to think. But his primary research interests are around drug discovery and development, and his academic focus is primarily on the management of genitourinary malignancies, hence our common interest in prostate cancer. So we've worked together for many years and very excited to work together with him again now as part of the new SAHMRI. So today he's going to be talking about prostate cancer. So where have we come from and where are we going in treating metastatic, very treatment-resistant prostate cancer. But I think he's going to give a few insights at the end of the presentation as well about SAHMRI and where we're going with that. So thank you, Chris, for coming and being our first seminar speakers, and I believe it's one of your first seminars here in Adelaide. So welcome and thank you.
Thanks, Lisa. It's absolutely fantastic to be back home and not be planning to get on a plane soon to go back to the United States and live there. So what I would like to do is first of all talk about prostate cancer. I'll give a run-in overview of this. I suspect many people are not familiar with prostate cancer and its treatment options and how we talk about prostate cancer outcomes, Kaplan-Meier curves and survival curves. So I'll over-explain for some people, but hopefully seeing a lot of new, fresh faces who may not be involved in clinical trials or clinical research reports. I'll spend a bit of time explaining what these curves mean. But as I go along, I want a lot of people to start asking the question, why? Why is that group doing well and this group doing poorly? And think about that in your world of how you see your research evolving over time and how your research can possibly answer questions related to prostate cancer, but also other cancers. See Jordan here and brain tumours. There's a lot of overlap between cancer biology gone wrong and how it drives cancers, and ask why. And then we can do biological experiments to address that. But also, is there more data that can be drilled out of these clinical trial data sets to answer questions? So there's an evolving world of clinicogenomics where we get all the clinical features and we match it to biological features of exome mutations, gene expression profiles, and we're starting to evolve and have data around that. So I just want you all to ask why and not go to sleep. So conflicts of interest. Being a physician who sees and treats patients, we also get advise companies on how to develop drugs. And there are conflicts that arise. So here is me being actively involved, but also getting paid for it. But also as being a part of clinical trials, you may look at your own trial and say, well, that's pretty damn good, and have a particular bias. So a couple of the studies that I've been the PI of is one called the Chartered study and another one called Enzamet. And just be a little bit forewarned that I'm pretty familiar and pretty excited about those studies. So prostate cancer, it's an extremely rare disease. You'll hear in one day, someone will say, oh, prostate cancer, we don't need to know about it. Men die with it, not from it. And then the next day you'll read a news report, Celebrity X died of prostate cancer, and you're going, well, what's this all about? And the answer is yes, there are a lot of men who have indolent low-grade prostate cancer on this left side, and we probably don't need to know about some of them, like an 80-year-old with a Gleason 6 being very low grade. And then there's the 50-year-old who presents with the Gleason 9 cancer, high grade, and high risk of relapsing and having metastatic disease at some stage. So even within this group, there's a variety of patients and their outcomes. And we have to individualize therapies based on age, their health status, and also the biological features that we know. So our treatment options are do nothing, watch it and treat it if it gets aggressive, radiation, surgery, radiation and hormones. If, however, a patient does relapse after that, there's this entity where the PSA goes up and their conventional scans, CAT scans and bone scans are negative, so that's biochemical relapse, M0 disease. But there may be disease that's micrometastatic to a CAT scan, but we can see it on a PSMA PET scan, these new radio traces that are emerging. And you can see this time frame to here, they get put on hormones. PSA goes up again with the low testosterone, so this is castration, low testosterone. PSA goes up with castration, this is called M0 CRPC, but you may still see disease on a PSMA PET. Then they develop disease on a CAT scan or bone scan, and the time from here to here is much shorter. So there's one path to castration-resistant disease and prostate cancer. Many of these men don't die of prostate cancer, but some do progress and do die. The other scenario is men who present with metastatic disease on a CAT scan after their first diagnosis. Some of these patients, it occurs de novo. 1 year they'll have a PSA of 3. The next year their PSA will be 50. And there's new disease on a CAT scan and a bone scan. And this is a very aggressive disease. And it's about 5% of all cancers, but it accounts for about 30% of men who die of prostate cancer. So why? Who are these men? Work in progress. Along the way, because it's convenient, we do a lot of our drug development in late stage prostate cancer because the time to show that you improve someone's survival from so many months to X months is a lot easier in the late stage disease. And that's why there's a lot of drugs developed in this late stage disease. But fortunately, we've now developed strategies to actually develop therapies in this setting, the metastatic hormone sensitive, when they're starting their testosterone suppression for the first time. And I've listed a number of studies that we've been involved in. This is the CHARTED study, which was the first one to show a survival benefit of adding anything to testosterone suppression. And then there's been a deluge of studies. And what's interesting is the pharmaceutical industry have been developing these studies and pharmaceutically sponsored because they get their drug on the market and get their return on investment. A lot of this work has been done by cooperative groups because the length of doing these studies is much longer. So this is why cooperative groups, taxpayer money, or pharmaceutical money paid to the cooperative groups to do the work for them is done, whereas this is pharmaceutically sponsored. So this is the area that I'm going to be focusing on, and this is the area where we have the most impact. So what are the life-prolonging therapies for men with hormone-sensitive prostate cancer until 2014? Well, I'm going to refer to it as weak androgen deprivation therapy. When you step into this field, you'll see a lot of lingo. ADT is what we use a lot of, but there are now many versions of androgen deprivation therapy. The most common first one was taking men's testicles off and seeing regression in the 1940s at the University of Chicago. Huggins and Hodges, Nobel Prize linking testosterone androgen receptor to prostate cancer, or testosterone and then found the androgen receptor later. And then there's medical ways of decreasing the production of testosterone by the testicles, LHRH agonists, antagonists. And then there were never any phase 3 studies of testosterone suppression versus no active therapy because it was well tolerated and very effective. So we didn't document how much of a survival benefit there was of testosterone suppression versus nothing. But overall survival benefit was seen when we did early hormonal therapy, immediate testosterone suppression versus delaying it. Then testosterone suppression with these medications versus a weak anti-androgen, something that directly binds to the androgen receptors and without the testosterone suppression. And then a slight benefit for adding the weak anti-androgen to testosterone suppression over the testosterone suppression alone. Bonus points, and we can talk about this at the end. What else was happening at the University of Chicago in the 1940s? And could this have been a cure for male aggression and nuclear warfare? History books. So prognostic variables associated with testosterone. That joke goes down variably well in different countries. So prognostic variables associated with testosterone suppression monotherapy. So what we know is men who present with de novo metastatic disease for the first time have a worse prognosis versus men who present, their disease relapses, their PSA goes up, you watch them a little bit later and it's a slower disease. We also know men who have more cancer on a CAT scan or a bone scan have worse outcomes than men who have less disease. So at Dana-Farber, I got all the patients within our databases, and we looked at the men who had no low-risk disease, namely PSA disease that was seen after their surgery or the radiation, 1 or 2 bony metastases, and you can see their survival is this blue curve, where many of the men are just living for many years when you just start with testosterone suppression alone. And it's about a median survival, half the men will die by about 7.7 years. Whereas in this other curve, the other extreme is the man who has de novo metastatic disease, they have rapidly progressive disease, and you can see half of those men are dead by 3 years with just the testosterone suppression alone. How do we learn this? By treating patients in clinical practice, getting the databases, and actually analyzing the data. And wouldn't it be great to get their genomics and seeing what's different between this patient and that patient? Why? Why? Keep asking. We are asking. We also know that there's a various distribution. Most of the clinical trials will have men with the rapidly progressive disease because they're the ones where physicians are more likely to present them to a clinical trial. So the rate of these patients presenting in these different formats depends on where you are. So in a heavily screened patient population or PSA tested, which is Australia, although we don't talk about PSA screening because we overdiagnose, but we still do it. Whereas in the UK, basically they don't do any PSA testing. So they'll have 17% of men present with de novo metastatic disease, where it's 5% in Australia and the United States. So we'll have more of these patients because we try and find them earlier than you would in the United Kingdom, for example. So what did we know? So disease that was growing despite a low testosterone, castration, we first of all knew in 2004 that the green curve, those who got docetaxel, were more likely to be alive out to 2 and 3 years if they got the docetaxel versus if they got a prior agent called mitoxantrone and anthracycline. So docetaxel is a microtubule inhibiting agent, whereas the mitoxantrone was a weak anthracycline. So there was a survival benefit. We also learnt when you added abiraterone, which decreases extragonadal androgen synthesis that comes out of the adrenal glands, that was driving some of the cancers despite having low testosterone. You gave that to men with prostate cancer with castration-resistant disease. They lived longer if they got the additional hormonal therapy on top of the testosterone suppression alone with prednisone in this case. And then there was this drug, enzalutamide, which is a much more potent binder to the androgen receptor than the weak anti-androgens I mentioned, bicalutamide, also known as Casodex. So basically they showed that men lived longer when you added an androgen receptor inhibitor that had potent binding to placebo. And what I would say about that is that enzalutamide has been developed and is much more potent at the molecular biology level. And what is found out with time, and Wayne Tilley was involved in identifying, characterizing the androgen receptor, is that when you lower the testosterone, the androgen receptor goes up. There's an upregulation saying, feed me, and that's why they're resistant to castration, but they're still responsive to some hormonal manipulation. So is there biological rationale? So this works a little bit in metastatic castration-resistant prostate cancer. What about if we use it in metastatic hormone-sensitive prostate cancer? That was a question that I asked in 2003. It is now 2023, and it's the 20-year anniversary since the concept of that study, and we're finally closing down the study called Charted, which was based on this study. So yes, I had more hair 20 years ago. I've got the passports to prove it. So the most successful strategy for developing anti-cancer combination therapies commonly adhere to the following principles: distinct mechanisms of action, single agent activity, and non-overlapping toxicities. We have cured some metastatic solid tumors with this and some lymphomas and leukemias with this strategy. I see the young Dan Thomas here. So examples would be anthracycline plus cytarabine with leukemia, CHOP chemotherapy for non-Hodgkin's lymphoma, bleomycin etoposide and cisplatin for germ cell tumors. But these are particularly more sensitive, but you needed multiple drugs to follow these principles to give them at the same time to eradicate every last clone and cure patients. So since 2014, when the first study read out of ADT, testosterone suppression with or without docetaxel, called the Charted study, there's been a deluge of new studies. So testosterone suppression plus or minus docetaxel, a French study, an American study, and a UK-based study, all with the same accent, but pretty much the same result. Different accents, same result is what I'm trying to say. Abiraterone was also tested when started with testosterone suppression rather than waiting until progression. Latitude and Stampede are the names of those studies. Androgen receptor inhibition with enzalutamide or apalutamide, Enzamet, Arches, and Titan. What's interesting is the Enzamet, all of these studies were cooperative group studies paid by taxpayer money, or pharmaceutical investigators pay cooperative groups to do the work, and the cooperative groups own the studies. But finally here, Enzamet, we got this study going through the Australian New Zealand Urogenital Prostate Cancer Group, a Cancer Australia supported cancer trials group. So we got that one going first, and then the pharmaceutical companies sort of said, if you're doing it, we may as well do it too. So we basically encourage them to get into this space. Then there are studies of radiation to the prostate in men with low volume disease who have a survival benefit. If you radiate the primary, give the hormonal therapy versus just the hormonal therapy alone, these men live longer if you radiate the primary. So sometimes the primary control, even in the face of metastatic disease, is relevant per this study, these two studies. And then there's this question, well, what about all-in? Chemotherapy plus testosterone suppression plus the new hormones versus the chemotherapy plus the testosterone suppression alone, or the alternatives, the potent hormones, all various versions. And this is what we are starting to evaluate now, and I've got some new data on that. So we now have multiple life-prolonging treatment options for men with metastatic hormone-sensitive prostate cancer. But to have a survival benefit, you need to overcome the benefits of sequential therapy. So A followed by B equals C, whereas A plus B followed by standard therapy equals D, which is better than C. So that's what we have to see in clinical trials to see if combinations and giving everything up front with the associated toxicities is beneficial. But which patients benefit from which therapy? Not everyone needs everything at once. So we need to try to personalize therapy, and I know there's precision medicine themes within this august environment called SAHMRI. Right now we have clinical factors that have been describing, developing, but we're trying to actually underline the genomics that's underlying that. And I can see Luciana Matulato just talking about, oh, just give me the tissue, spatial transcriptomics, I'll get it for you. Kelly says, but we don't have, got to get the machines running. So here is the first shot on goal. So this is the study of testosterone suppression with or without docetaxel. So here are the patients who have synchronous high volume disease, the worst prognosis, and they had the most benefit from adding the docetaxel. So the most rapidly progressive disease had the most benefit from adding the cytotoxic agent. Whereas on the other side, you see this group here, the metacrinous low volume, best prognosis, no benefit from adding the docetaxel. It's only taken me 8 years to convince the UK that this was true, because they had a study that didn't have those patients in it, and they said, well, no, that's not right because we don't have it. That's another story. So not only is there personalities and politics and science, there's just patience you need to actually generate the right data set. So now we've all come together and combined all of our data, and we can see with all the studies combined, Chartered, GTUG, the American study, the French study, and the UK with a couple of European sites, you can see that the increase in the 5-year survival was 12%, 4% in this group, but small numbers and uncertainty in the confidence interval, but basically that group does look like that group. Low volume synchronous, there is a small benefit, but these patients benefit from radiating the primary alone. So can you do a much more precise control of their AR negative disease with radiation instead of systemic chemotherapy? But this group had no benefit. So clearly there must be some underlying biology showing that difference in behavior. That's a why question, isn't it? Has anyone got an answer? So we're trying. So in 2003, who knew what technology was going to be available in 2020 to ask these questions? People doing PEEPs, and we had to also rely on formalin-fixed tissue. So we also had to consent it to say to patients, we want to use whatever technology evolves in the future. So we did that in 2003, and we got lucky, but we had a lot of consultation and a lot of people, you can't do it, and you just got to keep going. Work your way to yes. So some people may be familiar with the PAM50 gene subtyping in breast cancer. So this was applied to the prostate cancer profile. We used an Affy array that is developed by a company called Decipher, which is now Veracyte, and they have these locked classifiers. They've actually developed a prostate-specific one, which we're about to publish, which shows pretty much the same result, that patients with a basal gene expression profile, no benefit from docetaxel. Half the patients were alive at 49 versus 47 months with those who got docetaxel or just the ADT alone. Whereas there was a much more impressive survival benefit. Patients who had the luminal B had a much worse prognosis. Half the patients died by 30 months. Whereas if they got the docetaxel, they were living beyond 52 months. This is an example of a prognostic marker, luminal B having worse prognosis, but also identifying men who benefit from a given agent for docetaxel. And I just saw some data from the weekend that we're seeing something very similar in an adjuvant setting in patients treated with hormones and radiation with or without docetaxel. This seems to be standing up. The Stampede have the data just about to be analysed. So cross fingers, we actually may show this across 3, maybe 4 studies in the near future. And then the question is, what are in those gene sets of luminal B? That's a work that's available. I don't have it here, but you can go through them and you can see things like MIBL2 and a whole series of genes that may be involved in cell cycling that differentiate between the two. And ZFP36 is one of them as well in the new classifier. Here's the study of radiating the primary with hormones versus just the hormones alone. And you can see men with a lot of cancer, more than 5 bony metastases versus less than 5 metastases, had a survival benefit. This is basically saying that there was about a 27% decreased risk of dying of prostate cancer. That's what a hazard ratio means. It means the hazard ratio of being alive. 0.73 means that there's a 27% decreased chance of death from that cancer. So when I use the word hazard ratio, 0.73, now if it's 1.2, that means that there's a 20% increased chance that the therapy was causing the patient to die. So 0.73 meaning 27% decreased chance of dying over the curve, that Kaplan-Meier curves that I've been showing. But it's easier to report 7% chance that chance of being alive in the low volume groups went from 70% to 77% at 3 years. And we use that term for a landmark analysis, just so it's easier. Median survival, again, just talking about the number of patients alive at the halfway, median is the time of which 50% of the patients are alive with treatment 1 versus treatment 2. That's one way of reporting the data. The other is just saying, well, let's say how many patients are alive at year 3, percentage versus percentage. And then hazard ratio looks at all of that, be it 1 year, 2 year, 3 year, 5 year. So the 0.73 is saying 27% chance over the next 3 to 5 years the patient will be alive if they got the radiation to the prostate early. here is a whole host of other data sets that have emerged. Stampede long-term results. You can see that the red is well above the blue, and this was in the patients whether they had low volume or high volume disease. But 95% of these men in these UK-based studies have metastatic disease. Stampede showed something very similar. So this is the short and the low volume and the high volume, the low volume above and high volume below. So the hormone approach works in these patients more than the chemotherapy approach, whether you have low volume or high volume. And that makes sense because even the low volume have the androgen receptor, and they actually may be more hormone sensitive than the high volume. And we've got data actually showing that emerging. And here is the Janssen-sponsored study called Latitude. Again, this was all patients with de novo metastatic disease, showing that patients benefited whether they had low or high volume, but they all had synchronous disease. Titan was another Janssen study. They developed an androgen receptor inhibitor out of Charles Sawyer's lab called apalutamide. Light blue above red, more patients alive throughout. And you can see here the hazard ratio is 0.65, that number there, meaning at all points along the curve, 35% of the patients, there's a 35% decreased chance of dying if you get the apalutamide early as opposed to using the hormones when they're castration resistant. The median survival isn't reported because more than 50% of patients haven't died yet, especially on the apalutamide arm. So this is an example where we would report the 3-year survival or the 4-year survival where we've got reasonable numbers of both. And they looked at patients and they can see clearly that everything is to the left. So this hormonal therapy approach benefits all patients regardless of whether they presented with metastatic disease or relapsed with metastatic disease, whether they had a small amount of cancer or a lot of cancer. So Arches was the study that was sponsored by Astellas and Pfizer, or Astellas and the company Medivation, also a potent androgen receptor inhibitor. Most of these patients are de novo metastatic again, like the Janssen-sponsored study, because they do these studies where they get a lot of patients who present with metastatic disease, like Eastern Europe, although some patients are accrued in America and the United States. But what's interesting about the ENZAMET study is we had the greatest distribution of patients with some patients with synchronous high volume, the intermediate groups, and the best prognosis, metachronous and low volume. So this was it because it was a cooperative group study run in countries with good access to castration-resistant therapy and a broader patient mix instead of trying to get all the worst patients to get the best results as soon as possible. There is a little bit of undertone in what I'm saying there, but we won't go into that. But again, we see the benefit of the androgen receptor. Enzalutamide and apalutamide have the same effect. They're not two dissimilar drugs. All patients, low and high volume, metachronous and synchronous, all having a benefit. So ENZAMET, because it was not a study that was designed to get a drug approved, we said this is a study designed to work out which patients benefit from it. So it's a study that Ian Davis and myself and a few others, presented to the company Astellas and said, I went to the company, bit of a story, Majid Tabesh, Iranian, who actually had spent time fighting on the Iran-Iraq front. There's a picture of him in a firefight with his machine gun, a real one, on YouTube. So he's an interesting character. So he was working with the company. I said, well, wouldn't you know how we've done this chartered study? We're waiting for the result. He said, yeah. Well, how about we do it with enzalutamide? He said, yeah. And I said, can we do it? And he said, can you let me find my office? I've only just started. So then I presented the idea to him and he said, look, I've been speaking to people and they said, yep, we would like to do it, but the Americans don't want to do it. They want to do it. They don't think there's a market for this, but we think it's a good idea. So I said, well, I can run it as in the cooperative group study. He said, no, that's way too long. And I said, okay, I'll take it to the Australians. They're so much better. So I put away my American passport, pulled out my Australian one, and this is the ENZAMET study. The shenanigans that go on, that's another story. But this was much more patient-oriented in its design. So some patients, we also saw that patients, when the study was activated, after it was activated, 3 months later, the charter study read out, and we were the only study that actually amended the study halfway through to actually ask the question of patients who are fit for docetaxel, can they also get a benefit from adding the enzalutamide on as part of a study? So we have all the subgroups, and it was an opportunity to describe the outcomes of the different groups. And patients were treated contemporaneously. So a fit patient who could get chemotherapy versus a patient who was not fit for chemotherapy and just got the hormones alone. So we could start to map out the different outcomes. So what we do know is that one study called Peace 1 run by the French, where they only accrued patients with testosterone suppression, docetaxel plus abiraterone versus the chemotherapy approach, adding the early abiraterone on made a benefit in patients with de novo metastatic disease. Then there was this other study called ARASENS, which is another AMID, darolutamide. Again, a 29% decreased rate of death, very similar to the 25% decreased rate of death in all de novo metastatic. And then we actually see exactly the same thing in the Australian-led, but we had Canada, America, Dana-Farber, another reason why we didn't go out beyond Dana-Farber, Cancer Trials Ireland and ANZUP. And what you can see, interestingly enough, our survival here is much better than the survival from these studies with the testosterone suppression and docetaxel alone. So for some reason, the patients in this study who got docetaxel had a better survival just with the control arm, things to be explored, but still, despite that, you can start to see adding the enzalutamide still had a survival benefit in these patients. But what about the alternative combination? Could you have done just as well with just adding the hormone without the docetaxel? We really don't know, but we start to get some inkling of that information from the ENZAMET study, and that's what I'm going to drill down a little bit on. So here we have left black above blue, adding the enzalutamide to the testosterone suppression docetaxel had survival benefit, but in those who had metachronous, slower relapsing disease, there was no evidence of a survival benefit with adding all things up front. So maybe these are the patients who just need the hormone approach without the chemotherapy. So when we look at all of these patient groups together, so in the top left, the synchronous high volume who have the worst prognosis, the purple are those who've got the triplet therapy, and you can see when you give chemotherapy, those with the worst prognosis have the best outcome with all comers versus testosterone suppression and docetaxel, testosterone suppression and enzalutamide, and the patients who do worse are those who just get the androgen deprivation, testosterone suppression alone. Whereas in all the other groups, there's no evidence of an early separation. So to our mind, the only people who seem to get an early benefit are those who have the worst prognosis. And as Eminem said, sometimes you get one shot, one opportunity. Cue the music. It's that bad. And I've used it 1,000 times. But thanks, Jordan, for the big guffaw. So here we have a big survival benefit in the early stage, but it really peters out in the later part of the curve. So the curves come together, and why is that? But what we can also see is that, look at this for the synchronous, metachronous low volume. We've got patients with, be it testosterone suppression or with or without the docetaxel, about 85% of the patients are alive at 5 years, whereas it's only 65%. A lot of people are saying those patients with low volume disease, indolent, you can just give them testosterone suppression and let them go. But even some of them need everything up front, because you've increased your chance of being alive at 5 years by 50% by getting the enzalutamide early. So, and that's way more controversial than you'd believe. Again, reasons that we won't go into. Here is the study of patients who had a little bit of cancer that you could see by choline PET, where you get radiated. People say, well, can't we just radiate those spots and see how they do? And what one can see is that there is some degree of early control with giving early radiation without hormones, the gold curve, but most of these patients got hormonal therapy eventually. So then there's another study done by the Johns Hopkins group, again, PSMA PET positive, so you can't really see it on a CAT scan. Sometimes you can. Also, see this, you could see this on a CAT scan, but if you radiate everything that was seen on a CAT scan and a PSMA PET, you tend to do okay with the radiation alone. And also, if you had a genomic marker with P53 or RB mutation, these mutations here, you tended to do worse. So there may be patients who can get by with a bzz of radiation, spot weld, and come back and see me in a year, and they may still not have needed to start hormonal therapy. That's something we're working on. But the flip side is, we also see that doubling down early, we do see a greater chance of being alive at 5 years. So we need to get more precise as to who benefits from the bzz radiations set and forget versus doubling down. Maybe you will do really well if we give 2 years of the hormones plus the radiation versus the hormones alone, and who knows? So this is all a work in progress. This is a study that I took down from Twitter because I don't have access to the slides, but this is the alternative approach of the hormones versus hormones plus radiation. And you can actually see that there's more durable control with radiating plus the hormones versus just the hormones alone. So maybe there is something to doing the radiation plus the hormones in these patients. So that leads to, I didn't update this, dash it, I saw it and I said I should update it, but I forgot, February 2023. This is how we see and think about prostate cancer. So we have patients who have the good risk, metastatic, low volume, adding the testosterone, adding the NHT, the new hormonal therapy to the testosterone suppression, maybe we should radiate them. Intermediate risk, 4 or more bony metastases, clearly they benefit from adding the NHT, but maybe there are select patients who benefit from docetaxel. The intermediate risk, the de novo, low volume, radiate the prostate, the new hormones, getting close to 90% survival with these patients at 5 years and hopefully longer. And then the patients who have the poor risk, chemotherapy, hormones, rather than either the hormones alone approach. I've been talking about overall survival, which is the composite of frontline therapy plus the disease for castration resistant. Here is the data of patients just being treated without progression. So this is the time to PSA progression. So we can see adding the enzalutamide drastically decreases the number of patients at any time who are having a rising PSA, the first evidence of progression. And you can see that across all the groups, purple and blue, better than the other two blues without the enzalutamide. Again, the purple is the one that got docetaxel with the enzalutamide. This group here doing really, really well. So we've got 70% of patients who haven't progressed yet at 5 years, and they're still on this enzalutamide. Do they need to be on it that long? Because there are side effects. And this is a very complicated slide, and I'm not going to go into all details, but I'm just going to, you know, the beautiful mind where you start seeing patterns? Well, can you see a pattern? Well, let me help you. So this is prostate cancer specific survival. We just talk about the chance that a patient's surviving from the prostate cancer and not dying of something else. Overall survival is death from anything, prostate cancer death or something else. In the synchronous high volume, most of the deaths are actually prostate cancer, so that's why most of these look similar. But what we can see is this group here, who didn't get docetaxel, were older, less fit, but they got enzalutamide. Their prostate cancer specific survival is actually doing quite well, but they're dying of other things here. So we're starting to see patients die of something other than prostate cancer for those who are having long-term hormonal therapy control. But these drugs cost a lot when they're on patent, but that's another story. Here we're actually seeing these patients here having a 90% prostate cancer specific survival, but an 80% overall survival. So 10% of them are starting to die of something other than prostate cancer in the long term. Being a cooperative group study, we are actually getting the support because we're cheaper than the pharmaceutical study. So they're actually supporting us to look at 7 and 10-year data, so we can actually take this out to here. And that's, again, the benefits of a cooperative group study, as well as getting access to the tissue. I was going to say something else about that, but so cooperative group studies are the best because we get more patient-relevant data sets. So can we de-intensify therapy? And this is basically showing limbo. The lower you go, the better. So patients who have a low PSA less than 0.2, are much more likely to be alive, whether they got ADT docetaxel, ADT abiraterone. So the top of these curves from all these studies are patients who have low PSA and they have the best survival despite what treatment they had, all the drugs. And this is another study with the apalutamide, and you really see the curves split. So, and data that we're just generating is its potential. We can use the rate of PSA at 6 months as a surrogate for whether the drug is really working, and use that instead of having a 10-year study, have a study that can be done in 5 years using that PSA surrogate. That's a work in progress. So you've all heard about all these other new therapies that are being developed, PARP inhibitors for prostate cancer, radioligands, lutetium PSMA, it's all over the news, although it's not approved in Australia yet. So all of these studies have all been shown to blue above the yellow, blue above the red, green above the blue. If you do hormonal therapy plus a targeted therapy, be it radioligand, PSMA to lutetium to PSMA expressing cells, PARP inhibition if you've got a BRCA2 mutation or the like, or an AK2 mutational profile, there's a survival benefit in castration-resistant disease. So is it rational to take these studies back? I think so. And again, this is the most successful strategy of distinct mechanisms of action, single agent activity, non-overlapping toxicities. And these studies have started. PARP inhibitors, lutetium PSMA, there's a CDK4/6 inhibitor and a capivasertib. They're ongoing. Some of them may win, some of them may not win out for patients. But here is how I see us going forward. It's a bit of a pipe dream. One thing is we get all the data from the Charter, the Stampede, the Enzimet into one database. And we run a global registry study because not all these patients can have access to these therapies. Not all patients are fit for these therapies. And we still need to start to get an idea of the PSMA, what happens to the PSMA PET on therapy, when should we be giving the lutetium PSMA, which may be damaging the bone marrow and causing leukemias later, especially when we're having patients living beyond 5 years. Bone health, comorbidity, but social determinants. What is stopping, and this was a big conversation Steve Wesling here was steering us towards starting to think about why are patients not getting the optimal therapy? Why is a patient in the Narlan area, speaking with Chris Hocking, he has trouble getting his patients into the clinics. What can we do to overcome those social determinant issues? What maybe happened to a person's childhood that they had some sort of abuse, for example, and they just don't trust anyone to show up to a doctor's office and they present late. These are things we need to also start to think about. Get all this data into a database and then just analyze the living bejesus out of it with artificial intelligence and the like. This is a goal. And hopefully we can get to a point where we can do studies. If your PSA is greater than 0.1, you get these intensification arms with the new therapies. So we don't give it all these toxic therapies to patients who don't need it. And maybe we can just do sequential in some. And so hopefully we may actually get to a point, instead of someone coming and seeing Chris Sweeney and saying, I think you got this, we should, this looks like the right treatment, but we actually have their gene expression profile and their PSMA PET imaging, and they can work out who needs the chemotherapy, the radiation, the hormones, or just an all-in versus a less aggressive approach. And then if you're not having a good response at 6 months, who do you needs the intensification with these new targeted therapies? So I'm just we'll come, so at 11:46, so a couple of minutes for questions, or do you want to go straight to SAHMRI? Perfect. So this is a visual I like, actually. Have you ever seen this one? So I'm going to pause, see if I can pause it. Oh no, that goes back. Or maybe I'm not that good. Well, I do know I'm not that good. So what is the South Australian Immunogenomics Cancer Research Institute, SAIGENCI? That research shouldn't be there. I typed that in a hurry this morning. So it's a collaboration of the University of Adelaide and Callan. SAIGENCI is the newest cancer research institute in town. So it's parts of level 6, level 8 and level 9 of the AHMS building. There was an $80 million establishment grant from the federal government to support this entity, with support also leveraged from the University of Adelaide and Callan. So this is a group of people who came together and said, we really need to work out how to do good work together. And the way we're investing the money is twofold, is invest in fundamental and laboratory and translational research with close links to clinical trials, tissue banks, clinicians and their patients. So it's really amazing to actually also have the Comprehensive Cancer Centre coming into play and a new $80 million investment in cancer research at the same time. And the focus of SAHMRI is to bring in new talent from outside Australia, South Australia, to add to, and new technologies to add to the excellence that's already here. So the notion that we can have more people on the South Australian cancer fighting team and then link into, but we need close coordination, and Steve and Tim Price and myself, we're all talking about what will the CCC lead versus what will SAHGENCI and what will Cancer CCB and UniSA and what will SAHMRI lead from its basic science research. We have an amazing opportunity to all achieve the goal of fewer patients develop cancer and improve the lives of those with cancer. Similar message to a lot of other people. I'll be frank, a lot of people actually don't know where Adelaide is in the world. When you go overseas, they say Adelaide. So I've reverted to this map. So Sydney, Melbourne, Adelaide, great. So we need to work, hopefully by having more international people coming in, the seminar series that we're talking about, we can help further establish Adelaide in the map. Because look at that. That is an amazing visual of what is going on in the Adelaide Biomed City. Obviously, you know where we are. But I do like the fact that someone actually got this in here before it's even there. The glass is going on the outside. So New Proton Centre, AHMS in here, UniSA, SAHMRI building where we are here. We're probably right there, aren't we? And the Royal Adelaide Hospital. I mean, it's amazing. That's an incredible precinct. I look at the Longwood area in Boston. It's not too far off there. The other amazing precinct that you can see is Toronto. Of the two amazing precincts in the world, Longwood Medical Centre and what's the street in Toronto? That's all. University Avenue, linking the University Health Network, Princess Margaret, six sick kids, and the university itself. It's fantastic. I think we're right there. So how are we setting this up? So we're focusing on 4 programs. Resistance prevention, and we're actively speaking to a recruit now, and then try to see if we can bring in a molecular pathologist to supplement the work that SA Path and Hamish Scott doing for new panels. The goal is to be tissue agnostic in this group, but then have a sub-program with hormone-dependent cancers with the ongoing work of Lisa, myself, Breast Cancer Lab, and then collaborations into the Dame Roma with Wayne in the team, and then have a focus on pediatric and neuro-oncology to leverage the proton. And there's a recruit with Laura Genovese and Mel Davis, and they've just got an NHMRC Ideas grant. That's a work in progress. And then program in cancer epigenetics led by Jose Polo in collaboration with the ACE, hello Herman, represent. So, and Sandy, good work. So we have Luciano running a lab with the spatial transcriptomics and technology development. Adrian Sullivan's been recruited coming from the CRIC, plus 2 more into that. Mel Davis, who is running the computational systems oncology program, where she's bringing in someone to help with bioinformatic core services, who's coming from the New York Genome Institute, Belinda Corns, an Adelaide girl coming back home, and recruiting other people to add to what I think, if we can manage data, we'll actually be able to be leaders in many of the cancer research fields. And a tailored immunotherapy, actually I should have changed that title. Brendan Jenkins from the Hudson Institute has just signed on, and he'll bring in, he's going to run a program. His work is on innate immunity, macrophages and whatnot. He's looking to bring in an NK cell immunologist and a adaptive immunologist as well. And then we've got a great administrative team to help connect all the dots. But the last thing we want is for SAHGENCI to be sitting on level 9, 6, and 7 as an isolated entity. We don't want to be an island of an archipelago where you've got islands and no one's connecting. So the goal is to connect with amazing research in the University of Adelaide, Bearden's, and SAHMRI and CCB, recognizing we may be Adelaide University soon. But the cross-disciplinary, interdisciplinary research, engineering, I've already spoken to engineers about a number of projects we're doing. Roseworthy and growing medicinal products that may have drugs in it that we can extract. Speaking with Mark Hutchinson and a fellow called Tony Hooker, and radiation biology, and can some of our drugs that actually have anti-cancer properties enhance radiation in cancer cells, or can they be used as radiation protectants? There is an amazing amount of opportunities that if we coalesce and develop a precinct-wide approach, and desperately hoping that SAHMRI can contribute to a precinct-wide approach, and we can do some amazing stuff. And it's so exciting to be back in South Australia. So thank you, everyone.
Great, thank you so much, Chris. Is that getting the microphone right? So probably we can open up this up for questions, but it's been really exciting, I think, to hear both from the scientific point of view and the precinct point of view. I think they actually share a number of parallels that, you know, we're talking about a period in prostate cancer not that long ago where there were very few options for men with metastatic disease, and now the trials you're showing us, I mean, there's just, you know, it's just ripe for further research and options for people. But similarly, the precinct, you know, there wasn't much down here, you know, 10 years ago either, and now look where it is. But I think both share that common factor of how do we do things most effectively, and what's the right way to do things in a way that you know, I think is very synergistic. So I think it was actually maybe unintentional, but I think some good parallels there. So we'll open this for questions for Chris.
And as you're going over to Jordan, I'll just say that if we always put the patient first, a lot of issues, inter-institutional lab, competition and whatnot, if we always put the patient first, things can often be solved. So at every step of the way, if we do that, I think we'll make progress. Jordan.
Great talk. Question for you as a non-adult medicine person. Your numbers that you have in your trials, I'm very jealous of. But I think it then affords some questions to ask, and perhaps it's already been done, I don't know. You know, men who get prostate cancer in their 50s are different than men who get prostate cancer in their 70s.
Is that right?
Well, I would think in terms of vitality and other things.
Absolutely.
And so my question is in your survival curves, if you break them down by age of diagnosis, is there a separation between responsiveness to therapy with different drugs?
That's the type of thing that we're trying to answer. So within the Enzymet, because we didn't mandate everyone needed chemotherapy, it was a physician choice. So we actually do know that the men who just got the testosterone suppression with or without the enzalutamide were older, had more ACE comorbidity index, so they were not fit for chemotherapy. And so that's why I'm drawing out that prostate cancer specific survival. People are going to be groaning about me doing that, but it's starting to ask that question. We're seeing those who didn't get docetaxel, they were more likely to die of something other than their prostate cancer at that 5-year mark. Versus, you're absolutely right, the man in their 50s, we probably want to be much more proactive because their longevity is 20 years, 30 years, whereas a man who's diagnosed at 82, we may need a very different approach to them. The challenge is those men tend to not end up on clinical trials because they don't fit eligibility criteria. So that's why we need to do projects like this where we just say in standard of care what's happening in the real world to answer those exact questions. But when we do look at men who are more than 75, less than 75, who got docetaxel in the charted study, they had the same benefit, maybe even a bit more, but they had to be fit to get on the study. If that makes sense.
Okay, Dan?
Yeah, interesting talk. In lymphoma and intermediate risk leukemia, our survival curves usually plateau at a certain point. And now when we go and check out those patients, we see we just can't find, you know, minimal residual disease, and we're beginning to use that word, you know, cure. In your metastatic survival curves, some of them seem to have some plateau of stable survival, others didn't. Do you truly believe there are people with metastatic prostate out there that have honestly been cured, or do we still need to find major new targets, modes of action?
It's similar to breast cancer in a way. So there's the whole conversation about tumor dormancy, or some of these men going into a deep sleep and then it doesn't wake up when they die of something else, versus true eradication. So that's what part of the intensification question is, can we stop therapy and see how many men have their testosterone recover and their PSA not rise again? So that is a new way of approaching this that we're thinking about. So right now, minimal residual disease is PSA less than 0.1. stopping therapy and see what happens. It's controversial to do that, but we're talking about that. 6:30 every Tuesday on a phone call with Foundation Medicine to start to look at methylated ctDNA and ctDNA from some other studies. And we do plan to actually, we've got the plasma to do that in the ENZAMET study. So it is the next generation of work we're trying to do to say, can we de-intensify and potentially have some patients not? I have treated a number of men with de novo low volume disease who have radiated their prostate, radiated their bony metastasis, given them testosterone suppression for 2 years, stopped it, and 8 years later, they're writing books and writing movies and things like that. And he acknowledged me in one of his books, and he's putting my name in it, but he misspelled Sweeney, so we had to correct that. But so yes, so he is a character. Used to fly fighter planes and then for United Airlines, but he's funny. But these anecdotes are starting to emerge, and people are starting to recognize that maybe some patients are cured, potentially.
I just wanted to say thanks. That was a great talk. I'm an ex-prostate cancer specialist nurse, so for me,
fantastic.
I found that very brought it all together. I now work here in consumer engagement, so I just had a question for your plan, your research plan. If you want to, pop that slide up. Do you have a section, which I couldn't see, for a consumer engagement, considering that it's so important now with researchers?
For sure, actually. Funny you ask that. So Catherine Hudson, our institute manager, was on a plane flight back from an SAHMRI meeting in Canberra and said to a lady, well, that's a really nice scarf. And that led to a conversation, which led to an introduction to a lady called Melissa Cadzow, who we actually are starting to have conversations. So yes, definitely planned. Do you know Melissa? You should. Yeah, she's very special. She actually is on numerous MRFF and NHMRC boards and things like that. But yes, 100%. So absolutely, like I said, if we put the patient in front. Actually, I'm in an argy-bargy with the university about this, going through a whole sense of legal hoops because they're just afraid to sign something because, we're custodians, we want to make sure. You're holding up the work. The patients want you to do the work. They don't want you to be afraid of them suing you because they actually want you to do the work. So we need to put the patients in the conversation. So yes, please. And I can connect you with Melissa. She would love it.
Yep, stop the back.
But that also speaks to some of your conversations on plain plant turn out to be really fruitful. So have a smiley face.
So back on the slide with all the phases of how you want to do your research on that, I remember you just offhand said something along the lines of it'll be one before. Analyzing the living bejesus. Yeah. Well, and you said that it'll be, ideally a individualized therapy to each patient. But I'm just wondering, how can you test a given patient to choose which one of the many possible therapies and many possible subgroups that the patient might belong to? How can you identify that with a clinically relevant test? Because without hours and hours of data analysis, that's infeasible for the future. I just wonder how in general would that model work? So the answer is by doing it by collecting the specimens within clinical trials, you'll have treatment A versus treatment AB, and you can see the gene expression profiling. So that Vericide is actually a commercially available assay where they run the AFI array, and patients being characterized for high and low risk localized disease. So it's a lockdown, clear America certified assay, and could be deployed in Australia through that. So that's just the AFI array. Commercially available, clinically deployable. The exomes, PIK3CA, AKT, BRCA2, that's all part of the gene expression exome panels that can be developed, like Hamish Scott has them developed for the MOST program and things like that. So these assays are actually clinically deployable and commercially available in certain circumstances. What's reassuring is that in the metastatic hormone sensitive, we don't have to biopsy the distant tissue. We don't have to rely on the circulating tumor DNA. The primary tissue actually is very representative. Now, once the patient gets to castration-resistant disease, clonal evolution and what's in the castration-resistant disease is sometimes, but not always, different to what's in the primary. And that's where the ctDNA actually may be of interest.
Maybe just, oh, sorry, Joe.
Hi, Chris.
Hello, Joe.
I come from Lisa's lab, so a prostate cancer research background, and we'd be interested in understanding what's going wrong with the men with the new treatments at the end point. Any information on the molecular profile, something we could be targeting for the men that fail these new treatments? Where do we go from here?
So my approach, Joe, has been to say, can we avoid that by actually going to the super early stage? This is a little bit self-serving, but hey, I've got the microphone. So my goal is actually to spending a lot of time on the research of preventing men relapsing, so intensifying the therapy. So 2/3 of the deaths occur in men who have localized disease. So can we intensify that therapy and prevent them progressing to hormone sensitive and castration resistant? Can we augment the therapy here such that they have prolonged remissions and die of something else? What we get up here is a complete haywire of disease, and we have meaningful, durable remissions in some, but not most, with a targeted therapy. So we will need, once it gets to here, what are the key targets and what's going on? So even the radioligands, they'll have a cancer control for some of the cancers, but others grow and the patient dies of that cancer still. So we have a whole series of new drugs developing. We need to work out how best to match those in the combinations. It's late stage disease, it's epigenetic mutations, epigenetic changes are driving it, and we're getting these transitional states to neuroendocrine, but it's not, and maybe some exome mutations that happen subsequently to that. So only in a minority so far does it seem like exome mutations are drivers, and it's more epigenetic changes. Having said that, it's hard to target epigenetics. We can have a 3-day argument around that, but I'll be right in the end, because again, I've got the microphone. But the other, can we start to identify the key transcription factors and develop inhibitors to those transcription factors? And how do you inhibit transcription factors? That's another 3-day conference and work in progress there. So I think my answer is, I think it's finding new drugs for the driving transcription factors.
Just bring it back to the patient again, by bringing those treatments back earlier in I guess, healthier patients. How does quality of life play into it all?
Yeah, no, it's a really good question. We have published the quality of life data from the CHARTED study, the CHARTED and the ENZAMET study, and even the chemotherapy, by getting the cancer under control, those who had the worst disease actually controlled the cancer and they tolerated the chemotherapy, their quality of life got better. So it's a combination of cancer control and the cancer side effects, the treatment side effects. You'll see all the pharmaceutical studies, they look at the global analysis, they put the two together. Their treatment is always a little bit worse, but overlapping, and they say no difference. But when you get down to granular details and saying, okay, this patient population may have more side effects than benefit. So yes, we do those analyses. We do know that enzalutamide has some degree of cognitive and fatigue. That's about 10% of the patients who just can't tolerate it, but can they get a dose reduction? Darolutamide has less of that. So we're trying to, yes, on one side of the equation is the cancer control, the other is matching the side effect profile to what a patient can tolerate, and that's a work in progress. But again, the more we can have active, independent investigators not tied into the commercial interests, the better.
That's probably a good philosophy to end on. So
I'll just go to my conflict of interest slide. Yeah, and I'm sure with the commercial interest people are sitting here, they're going, yeah, he's not coming back. He's not coming back. All right, but thank you very much, everyone.
Yeah, no, thank you so much, Chris.